ನಾವು ಮಾಡ್ತೀನಿ ತಗೋರಿ ನಮ್ಮ ಬಿಟ್ಟಿದ್ದು ಆಯುರ್ವೇದಿಕ್ ಕಳ್ಸೋಣ ಅಂತ ಹೇಳ್ತೀವಿ ಅಂತ ಮಾತಾಡಕತ್ತ
ಹಿಂಗ ಅದನ ರೀ
ಅವ್ರ ಇನ್ನೊಂದು ನಮ್ದು ಈ ಅಂತ ಸ್ಟಾಫ್ ಇಲ್ಲ ಆಮೇಲೆ ಯಾರ ಕಡಿಮೆ ನಾವು ಮಾಡ್ತೀನಿ ತಗೋರಿ ನಮ್ಮ ಬಿಟ್ಟಿದ್ದು ಆಯುರ್ವೇದಿಕ್ ಕಳ್ಸೋಣ ಅಂತ ಹೇಳ್ತೀವಿ ಅಂತ ಮಾತಾಡಕತ್ತ
ಹಿಂಗ ಅದನ ರೀ
ಅವ್ರ ಇನ್ನೊಂದು ನಮ್ದು ಈ ಅಂತ ಸ್ಟಾಫ್ ಇಲ್ಲ ಆಮೇಲೆ ಯಾರ ಕಡಿಮೆ
Good afternoon, everyone. I'm Dr. Pavneet, one of Dr. Bindra's student, and it gives me immense pleasure and honor to welcome you all to our Homeopathy in Cancer Care webinar. Cancer, the term in itself scares most of us, and a cancer diagnosis is not just restricted to the individual, it impacts the entire family. A physician's role is not just restricted to being a doctor there, but a psychologist, a caregiver, and sometimes even a friend. You don't just treat the patient, you treat the entire family and give them a new hope of life. Having said that, cancer treatment doesn't always mean cure. Palliative approach, maintenance therapy, hospice care are part of the treatment plans. A homeopathic physician should know the scope of homeopathy in cancer care. Also, we should know when to say no to a case. To guide us and mentor us in this journey, we have with us today one of the most inspiring homeopathic physicians working in the field of homeopathy and challenging the modern medicine with his approach. He is also the medical director and senior consultant of Cancer Care Center. Yes, you all guessed it right. He's our very own Dr. Bindra. He would be sharing with us his insights and experiences when it comes to cancer treatment. We also have a special guest with us today, Dr. Arun V. Huli. He's the principal of BVVD Homeopathic Medical College and Hospital in Karnataka, with whom we have an academic collaboration. Dr. Huli is a master of his field and has great accolades under his name. Sir, it would be a delight for us if you could share a few words and you can share your association with Dr. Bindra's super specialty clinics and cancer care center.
Good afternoon to everyone. So this is Dr. Arun Huli, Principal, BUS Homeopathic Medical College, Bagalkot. So we are very thankful to Dr. Bindra sir. Recently, he had come to our place. So we have conducted a national homeopathic conference. So theme was Globe in Globule. So the treatment of different approaches in the homeopathy and homeopathy for the masses. So he had given a wonderful lecture on the regarding the cardiology and the oncology. So this part of the students in the Karnataka state, nearly 1,150 delegates were there. So almost from all the PGs and even in the PG scholars, teachers and interns from the different colleges in the Karnataka and nearby states like Telangana, Tamil Nadu and Maharashtra, even from the people from the Pune and Jaipur and Madhya Pradesh. So they have got benefited and they are highly impressed by the Dr. Bindra sir's speech. So definitely today, all our students are attending this webinar. Really, we are very thankful to the Bindra sir. He has given an opportunity to collaborate with our college as well as attending our students as well as the faculty. And even we have shared all the link to the all the colleges of the Karnataka as well as in our institutions of different health institutes of our college. So many students who are attending this webinar. So definitely they will be get benefited. I have a hope and have a confidence on the Bindra sir. So definitely he will motivate the young budding doctors as well as even in our faculty. It is a benefit for the future practice. Thank you, madam. Thank you, sir.
Thank you so much, Dr. Huli. Thank you for your kind words. Guys, it's time for us to start with today's session now. And with this, I would like to welcome Dr. Bindra to take up the stage and do what he does the best. Over to you, sir.
Thank you so much, Dr. Pavneet. I am audible?
Yes, sir, you are audible. Thank you.
Thank you. Good afternoon, everyone. So today we all are here for the very important day in our life, because being a doctor, when you talk about something which is about cancer, because I'm practicing in cancer for last 7 to 8 years, specifically for the cancer patients, because in the previous 13 to 14 years of my practice, I have been seeing all types of cases, but for last 7 or 8 years, I am just practicing exclusively for the cancer patients in around 80 to 90% of my practice. So today, if I talk that what will be our approach in cancer patient, because when I talk about cancer, it is not a simple disease, it is not a complex disease. Why? Because till now, today we see what? Every patient who is coming to you is already exhausted by each and every system of medicine. I'm not talking about only allopathic system, I'm saying each and every system, because I see the patients who are already having the allopathic treatment prior to coming to me. They even took some homeopathic management from the other doctors. They took some Ayurvedic treatments. They took some other treatment also, like what we call the traditional Chinese medicine or the Tibetan medicine. So when the patient comes to you after this much of exhaustive treatment, what you can do? So first of all, starting this session with a very heartful thanks to the BBVS Homeopathic Medical College, Bagalkot, and specifically Dr. Arun Huli sir, who is such a dynamic personality that I met, I think in the last month when we were there for the this national conference on the homeopathy. Along with that, not only Dr. Arun, but his whole of the team, the college, the faculty, the staff, non-teaching staff, everybody is passionate about homeopathy. I went many times to other states also, but this college faculty is determined to do something for homeopathy, and which is very important for the faculty, because see, we people are teaching the practitioners, we people are training the practitioners, but when you are in a college, your duty is more than the practitioners, because you are generating the new generation of homeopathy, and more specifically the young budding homeopaths. So how you nurture them, that will be making a decision that how you people are getting the upcoming generations of homeopathy. So very heartfelt gratitude and thankful to BBVS Homeopathic Medical College, Dr. Arun Huli, Dr. Manjunath Patil, who is the person with whom contact I could organize that this today's event also, because he was the person who told me that, sir, we will be getting all this with your guidance, and we will be getting in collaboration. So I am very happy that all the students of the BVS Homeopathic Medical College, not only this college, but other Karnataka medical colleges also, people or the students or the faculty, they all are joining today. Some are here and some are watching live on the YouTube streaming. So without wasting any time, let's talk on that what we can do for the cancer patients, because today we are celebrating the World Cancer Day. The World Cancer Day is basically for this year, we have the close the care gap, because every year we have some different slogan for the World Cancer Day. So this year we have the close the care gap. So close the care gap means that whatever you are offering to your patients, that should be have minimal gap. And this is the call for integrative medicine. When we talk about cancer management, the integrative medicine is the most important thing, because I have seen in my practice that the people who are being treated, the patients who are being treated with the integrative approach, they are getting more benefit than the people who are being treated with a single system of medicine. I will not boast about my system, because see, we all know the cancer is a very complex disease. Till now, hundreds and $1,000 million are being spent every year on the research for cancer. But ultimately, what we people are getting, that every day we are getting a huge number of patients dying of cancer. So let me start with this. The cancer statistics in India. This is a very brief detail about the cancer statistics, that 7.25 lakh people, they die of cancer every year. And that registry is raising day by day. 1,700 deaths every day and 1 death every minute. So when we people are talking, every minute one patient is dying of cancer somewhere in our country. And this is a huge loss. Then we talk about the second leading cause of death. This is the cancer, which is second leading cause of death after the cardiovascular diseases. The estimated number of people living with this disease is 2.25 million. And every year, new cancer patients are registered in our country, and that is around 12 lakh people. So then we talk about the chemotherapy. Because see, when you talk about cancer treatment, the first thing comes to the mind of a layman is chemotherapy. Chemotherapy, I will not say it is a bad treatment, but the way it is being given to the patients nowadays, that is a not accurate way. A deadly treatment it is being proving. Why? Because out of 1,300 deaths, which we are noticing every day, around 400 patients are dying of the side effects of chemotherapy, which is a huge number, around 40% of patients. So 40% of patients don't die of cancer, they die of the side effects of chemotherapy, which is a big challenge for the conventional system of medicine. So when we talk about the basic evolution, because I will just give you a brief about cancer, we will discuss that exactly what cancer is, then I will jump to the management strategy in homeopathy. Then we will discuss some cases about cancer that were exclusively managed with homeopathy. And then we will see that what can be the role of homeopathy in collectively in oncology. So basic evolution of cancer is that every normal cell has a life cycle, we all know. Every entity which takes birth, it has to die someday. Not only we as human beings or the living animals, but every cell should die at some moment. And this is what we call the life cycle of a cell. It grows, it takes birth, grows, then it proliferate, function, and then eventually and spontaneously it dies. In a healthy person, this cycle goes on for the whole life. But what happens in cancer? That suddenly somebody who is living a normal life, and then immediately that cancer jerks in. There is a tumor on the neck of the patient. There is a breast tumor. There is a tumor in the liver. There is a tumor on the prostate. Why? Why this happens? Why the blood cells become collectively increased in number that we see in the leukemic patients? So basically what cancer is, it is a series of the molecular events that fundamentally alter the normal properties of the cells. So when these molecular events become at the threshold of the point, what happens? The normal control systems or the checkpoints, what we call, they all become unfunctional and they start behaving in a abrupt way, and ultimately what happens? There is the uncontrolled division of the cells, and this uncontrolled division of the cells lead to the formation of the tumors, the piling up of the tumors, and the metastasis. So in cancer cells, the normal control system which prevent cell overgrowth, overproduction, and invasion to the other tissues, that is completely disabled. So if I say that the cancer patient system is just like a rebel, it is out of the control. It is not following any commands of the body. It is not following any normal mechanism. It completely is out of control, and that is leading to the uncontrolled cell division. Now the question arises, why this happens? Because see, every effect has a cause, we all know. If cancer is happening in the body, there should be a cause. What is the reason behind all this? So when I talk about genetic mutations, the abnormalities in the cancer cells usually result from the mutations in protein encoding genes which regulate the cell division. So cell division is being regulated by certain protein encoding genes, what we call the genes which prevent overproduction, overgrowth, and once any damage occurs in the DNA of the cells, they lead that cell to the apoptosis. So normally the repair DNA damage are themselves not functioning. That's why they become mutated. Let me give you an example. If a patient goes to a doctor for a treatment, take an example that the doctor is suffering from flu, himself is suffering from flu, and the patient catches the second disease from the doctor. So now what happens? The person who was supposed to treat that patient is himself ill. That means now the patient will not be able to get a right treatment. The same thing happens in the cancer. The cells which were supposed, the genes which were supposed to treat the unhealthy cells, to prevent overproduction of the cells, they are ultimately mutated. So now what happens? That function is being completely compromised, and ultimately we see the overproduction of the cells, or ultimately what we call it as a cancer. Now looking at this soul, this person, this personality, this whatever we use for Dr. Henneman is less than anything. Because if you study Dr. Henneman's life, I always say that if this person could live 10 to 15 years more, then the system of homeopathy would have been totally different now. Because the Dr. Henneman was the personality who was the person who himself challenged his own recordings, his own observations, and every time he improved in the organ of medicine. Starting from for the first edition, second, third, fourth, fifth, whatever edition, sixth, up to six, we see. Every time we see that something new is coming and something old is going away. And this was the beauty of Dr. Henneman. Now what Dr. Henneman's view is about cancer, what exactly the cancer is. Before moving to that, I will say that what chemotherapy, radiation therapy, and surgery has to offer. Now see, what is chemotherapy? We all know chemo is simply just injecting the poison in the blood of the patient. And that kills not only the cancer cells, but also the normal cells of the body. Then we see the radiation therapy. Radiation therapy is all about burning the cells with the radiation. Third is the surgical resection of the tumor. They remove the tumor and they think that it will not grow again. But what we see, just within few days, within few weeks, or within few months, tumors start regrowing from the same path or from some other part of the body. Why this happens? Because the conventional system's approach about cancer is totally a failure. They believe that cancer is a localized disease. Their perception is that cancer is a localized disease and then it spreads to the other parts of the body, which is what we call the metastasis. But ultimately, Dr. Henneman has explained it in a beautiful manner that cancer is a generalized disease and it manifests at a local organ. That's why the patients who are being treated with the homeopathic system or other alternative system, there is 0% relapse chances, 0% I am saying. And in conventional or allopathic system, what we see, there is around 80 to 85% chances of relapse after complete treatment of the cancer. This is a big failure of the conventional system. Now, if I talk about the integrative medicine, because this year, World Cancer Day, they have mentioned close the care gap and strong alone plus unstoppable together. So what they are emphasizing on that you should adopt the integrative medicine approach. If I talk about the European countries and the US, America, you will see that their patients are getting integrative treatment for cancer. Not only chemotherapy, but along with chemotherapy, there will be a dietitian, there will be a alternative practitioner, there will be a yoga practitioner. So everybody collaboratively give the treatment to the patient and you see that their results are far better than the Indian system. Because here what happens, we people are seeing what? The allopathic doctors, they are infusing the chemotherapies again and again, this time with this medicine, next time with a new medicine, and whole of the remaining life of the patient, whether it will be few months or few years, that will be completely exhausted in the hospital setup. And this is not a right way of treating a patient. Quality of life, this is the first thing that should be monitored. That we will discuss again in the palliative care, but quality of life is the first thing that should be given to the cancer patient. So integrative medicine is the first thing that should come to your mind when you are treating a cancer patient. Now, what homeopathy has to offer in cancer, what is our approach, what we think about cancer, why we are different from the allopathic system. Dr. Henneman says that cancer is what? It is a subtle dearrangement. Subtle dearrangement, that means it is chronic in nature. But allopathic system behaves it like a acute disease. I will comparison of these two is very important because when you are treating a patient of cancer, what we see, the patient has already exhausted previous treatments, what allopathic doctor has to offer. Now, what we want to do, we want to offer a better approach, a better treatment, and that is the last option for most of the patients. So cancer is a disease which is chronic in nature, but imbalance of the vital force, which is subtle onset, and gradual progression, which throughout the vital force offers unsatisfactory resistance. When this resistance is unsatisfactory, the disease comes out as a clinically evident disease. So the imbalance that leads to the cancer occurs first on the general level. Now see, this is the biggest difference that we think and that they think. General level and allopathic system, what they think? They say that this is a localized disease and it progresses to the generalized disease. But we believe it is a generalized disease and then it is manifesting at a local organ or a tissue, then it metastasizes. So as the disease brought about by the imbalance of the vital force progresses, the cancer tumor manifests at the local level. So this is a huge difference between the two approaches. Now the dearrangement occurs first at the general level and the eventual expression, the neoplasm, the cancer, the tumor, that may occur at the local level. The individual susceptibility will predispose the individual to the disease proper in general. Now what happens? If I give you an example of COVID, we have passed 2 years back that COVID-19 in one family, all people were infected. But only 1 or 2 people were having huge symptoms, but few people were saying that I am totally asymptomatic. What does it mean? That the susceptibility is the exactly deciding upon that what disease will be causing to the person. How susceptible a person is about a disease, that is what exactly will exhibit in the clinical expression. So this weakness or the sensitivity of a particular part, viscous or the system will lead to the localization of the disease. Now carcinogenesis. Carcinogenesis means the step-by-step formation of the cancer up to the clinical level, up to the disease level. If I talk about Dr. Henneman's or Gannon of medicine, he has given a beautiful explanation about the carcinogenesis, not in a direct manner, but indirectly. If you emphasize it, it will lead to 4 major stages. One is the predisposition, second is disposition, then we have diathesis, then we have the disease. Now what these 3 are: predisposition, disposition, diathesis. Predisposition is the fundamental cause of all chronic disease, what we call as the miasm, that comes from the family history of the patient from generation to generation, which predispose a symptom to a particular illness. The miasmatic load can be determined by the study of the patient's family history or the past history. So miasm is the predisposing factor which decides that what type of diathesis this patient will be having. So cancer patients usually have a strong family history of the cancer or the family or the past history of the tuberculosis or diabetes. And that's why we choose carcinosin as an anti-miasmatic drug in all cases. Now see, many students ask me that, can we give carcinosin as a medicine to the patients who have the family history to prevent cancer? Let me make it clear that carcinosin till now has been well-proven drug for the active cancer cases, but you cannot give it as a preventive medicine. Don't be coming into the unevidence-based factors, because see, many things require questioning. If somebody says you that give carcinosin to this patient and this patient will be having no cancer in the lifetime, you should ask that what is the evidence behind this? Because today we are living in the evidence-based medicine world. Don't believe whatever is being coming to you on the way. So cancer is usually developing on a soil which is fertilized by tuberculosyphilitic miasm. So tubercular miasm plus syphilitic miasm, they go together in the patients of cancer. Then comes the disposition. So what is disposition? It is how we interact with the surroundings. Like I am sitting in my room, how I am interacting with my surroundings, with this computer screen, with this printer, with this wall, with this roof, how my mind is boggling with all this. This is disposition. How you interact socially with the environment, with your family, with your friends, at your profession, along with the mental and the physical attributes of a patient. That is what we call the disposition. So psychological stress, it affects the neuroendocrinal axis. Why we say that the people who are more into the stress, they generally have more chances of getting the cancer. Why? Because the neuroendocrinal axis is being tempered due to the psychological stress. Ultimately, it leads to the tempering of reticuloendothelial system, and that leads to the weakening of your defense host mechanism. And that leads to decreased immunity and increased susceptibility toward the disease, and that leads to the cancer. So stress is a well-known factor, but not an overnight stress. It should be a prolonged and continued period of a stress. Then come the diathesis. It is a phase where an individual has a strong tendency to develop a particular disease. Like we always say that pulsatilla people, they have a very, seat of action, this remedy has a seat of action to the pituitary axis, to the hypogonadal axis. If I talk about lycopodium, we say that it has affection for the liver. If we talk about nux vomica for the liver and for the urinary system, if we talk about the netramure for the skin, for the mind, so this is what we call the diathesis. The particular affection or tendency for a particular disease, and which during a stressful environmental stimulus initiate the onset of the disease. So this can be directly inferred by the study of the predisposition as well as the disposition. So up to this level, you can do something for the patient to prevent the disease also. And up to this level, the constitutional treatment of the patient is the best option to do. Like if you say that a patient is having a prolonged stress and he has a family history of liver cancer, so what you can do? You can treat that person with strict diet restrictions, along with the psychological consultation, along with the well-chosen constitutional treatment. That patient's tendency for that particular disease will definitely be reduced. And this is the plus benefit of the homeopathic system, which is not present in any system on this planet. That a disease which is impending, we can anticipate. Anticipation for particular disease, that this person can have this disease in the future. We can prevent that also. But that needs a systematic evaluation of the patient, complete history taking of the patient, then you can deal with the disease accordingly. So identification at this level helps in two ways. One is the constitutional treatment that I told you, that can build up the defense mechanism and awareness of the patient, the self-awareness of the patient, and avoidance of the probable this environmental carcinogens, as well as which other factors delay the onset of the disease. What we call the positive factors as well as the maintaining factors in homeopathic system. Now this comes the red part, which is the disease itself. And disease also comes in two stages. One is the preclinical and one is the clinical phase. What is this preclinical phase? In preclinical phase, what we see, the phase which extends from the inception of the cancer to the time that it produces the recognizable symptom. Means what? I am sitting here. I don't know what is happening inside my body, how my liver is. I can get a liver function test to the blood, but exactly what is happening at the very minute, at the molecular, at the cellular level, I cannot predict that. I don't know what can happen after 5 years from now to my system. And that is the preclinical phase, because as per the research, it is being concluded that cancer is not an overnight disease. It takes minimum 2 to 20 years of time to be clinically evident. That means if somebody is being diagnosed with cancer today, that person was having this stress on the system many years back. Not from today only, but many years back. That is the preclinical phase. Then comes the clinical phase, which is the phase when the disease expresses itself overtly through the signs and the symptoms. Now, this stage, the patient comes to a doctor. He will tell that I do have pain in the abdomen. I am getting the vomiting of the blood. I am getting blood in my stool. I am getting blood in my urine. My blood count is low. My hemoglobin is low. My RBC count is very high. So this can be the disease stage. And this can be evidently seen in the radiological investigations as well as the blood investigations plus clinical examination of the patient. Up to preclinical phase, you cannot evaluate the disease on the material level. Now, the smallest tumor is likely to be detected by the physical radiological examination will have a diameter of 0.6 mm. Now see, the PET CT scan, what we do for the cancer patients, it can detect even the smallest of the tumor, which contains only 108 to 109 cancer cells. So these things can be seen. It takes several years after the onset of the cancer to bother an individual and come to the attention of the doctor. So by the time the doctor is being reported for that, we always say you should have come earlier. Now you are in the stage 3, now you are in the stage 4, and now we cannot do anything for you. So this is the minute study that we should conduct in all cases, that sometimes the early diagnosis can save a life. Because in cancer, till now, my experience says that if the patient is up to stage 2, the chances of getting cured is very high. But if it is stage 3 and stage 4, the regressal of all the things, the regression, the repression, so everything is very difficult to deal with. So early diagnosis is the prerequisite in treatment of cancer, and that will be done by a doctor in a normal day-to-day routine cases also. So then comes the clinical phase. The patient goes to a doctor with a report, and there is a 5 centimeter tumor in the liver. Now doctor says that, okay, we will treat this tumor, but exactly they don't know what is happening. This is the tip of the iceberg. What you are seeing in the report of the patient, what you are seeing in the PET-CT, what you are seeing in the MRI, what you are seeing in the ultrasound, that is not the exact situation. That is just the tip of the iceberg. Everything is under that. And that's why the patients are getting again and again the relapses of the cancer, the reoccurrences of the cancer. So till the time clinical phase is evident, the disease progression is beyond the clinical approach to cure and has to be palliated. So that's why this poor success rate in cancer is evident, because patients are coming to the doctors at very late stages. In my practice, I have around 70 to 75% of patients who are the terminal phases. Terminal means I cannot save that patient. I can simply palliate the disease. I can simply give quality of life. I can simply increase the life expectancy. That's all. And why this is happening? Because either lack of awareness, wrong treatment choice, because allopathic treatment sometimes sort of, you can say, kills the immunity of the patient. And by the time patient comes to you, nothing is going to work for you. And that at that stage, you need to simply palliate the disease. So then I will call about the curative medicine, because the role of allopathic system, we have seen that they have 3 modes of treatment. One is the chemo, then the second is the radiation therapy, then we have the surgery. Now, homeopathy in curative treatment of the cancer, what role we have? We have wonderful medicines. Last month when I went to this BVS Medical College in Bagalkot, Karnataka, I shared few medicines also, that how we can select the medicines only on the basis of pathology. So today we will not go into that much detail, but I will tell you that what scope homeopathic system has in such cases, what we can do as a curative medicine in cancer. So this is the first case I am starting with for the day. That is the chronic lymphocytic leukemia B cell. Now let me tell you what is lymphocytic leukemia. Basically, this is the white blood cells cancer. Here what happens, the lymphocytes start proliferating at an uncontrolled state, and the WBC count, the TLC, total leukocyte count, goes into lakhs into the patient. Now for the students who are present in the session, the chat is open. Can anybody tell me what is the normal range of total leukocyte count in the body, the WBC count? What is the normal range? Anybody, just type in the chat box. Dr. Varun Gupta, 4,000, 11,000, yes, right. And what is the normal lymphocyte percentage count? Lymphocyte percentage normal. Lymphocyte percentage in the total leukocyte count. Dr. Varun says 35. No, it is about 20 to 40%, right? So that is the range. So In this chronic lymphocytic leukemia, what happens? This TLC count becomes progressively increasing, and particularly the lymphocytes, because this is the lymphocytic leukemia, and this patient was the stage 2B progressive. Now, what happened in this case? This was a 64 years female which reported with abdominal pain on the left subphrenic region. Let me tell you all one more important thing, that always try to make sure that you use medical terminology when you are presenting a case. Always try to use, and when you are talking to your teacher, when you are talking to a junior doctor, when you are talking to a senior doctor, always talk in the medical terminology. Because being a doctor, it is your responsibility that what you are talking, it should not be easily understandable by a layman. Why? Because sometimes you should explain the diagnosis to the doctor and it should not be easily perceptible by the patient. Many times you need to hide the diagnosis from the patients. Many families come to you and they say what? They say that the diagnosis of the disease should not be told to the patient. My patient many times come to me, the son says that, sir, don't tell to my father that he is a cancer patient. Don't tell to my mother, don't tell to my brother, sister, wife, because this is a psychological trauma for people everywhere now. Because cancer diagnosis means what? It means that the patient is having a death warrant type of thing. So when we talk about CLL, this patient was having the 64 years of age and night sweating was there, bloating post meals for last 8 months, and was on painkillers without any diagnosis made till date. Now see, what is the importance of the diagnosis? Dr. Hahnemann says in aphorism number 3. I always repeat this in my all conferences, all webinars, that aphorism number 3 should be the basis of your practice. Diagnosis of the disease, diagnosis of the remedy, and then application or the implementation of diagnosis of the remedy to the diagnosis of the disease. This is what you need to do. A simple practice way. People everywhere are confusing you that take this approach, you take your mind symptoms, you take the chest symptoms, you take the dreams. Somebody say you take the physical journal, somebody tell you the mental journals. Why? Dr. Hahnemann was a very broad-minded personality. I told you in the very initial part of the session that he was a very broad-minded personality. He never was stuck to a single platform. Whenever he felt this is the better thing than the previous one, he stepped up. And we people, what we do, we are very focused on a single approach, that I am this type of homeopath. No. Your approach should be as per the demand, as per the need of the case, because every patient is individual. What is individuality? When you talk about individualistic approach, we talk about that this person is different from the second person. Then why the prescriptions are same? I treat patients on the basis of pathological prescription. There is no doubt, and I proudly say that. But that is also individualistic approach. I individualize the medicines on the basis of pathology of the disease. This is a difference, nothing else. I see the pathology report, I see the histopathology report, I see the genetic report of the patient, then I individualize my medicine according to that. So what is wrong in that? Practicing homeopathy in a different way is not a crime. To all the students who are listening, be bold and accept the change. This is not a crime. You should be bold enough, and that boldness will come when you are having a knowledge. There is no shortcut to the knowledge. If you are writing a CT scan to an allopathic radiodiagnostic doctor, and you are not satisfied with that report, what he has given, do you have the guts to call him and tell him that I don't want this type of report? Tell me that exactly what is happening in this part. And that will come when you have the knowledge and the skills. So that has to come only with the study, and right study, correct study. So this patient was the stage 2B. Examination was done. Spleen was palpable 2 centimeters below the left costal margin. This is the first report of the patient. Complete blood count, and CLL is the blood cancer which you can simply diagnose from the this CBC report also. There are certain other investigations also, like the immunohistochemistry, the cytogenetics, the bone marrow examination, but a simple CBC will tell you that this patient has the CLL, the blood cancer of lymphocytes. Now, hemoglobin was 9.9 gram per DL. TLC count, the total leukocyte count, which should be less than 11,000, 4,000 to 11,000 normal. Here it is 1,99,300. Then the lymphocyte percentage, which should be 20 to 40, here it is around 95%. Means what? The 95% of the white blood cells which are circulating in the body, they are lymphocytes. So where is the space for neutrophils? Only 3% of neutrophils. So what will happen in this patient? This patient will be prone to infections because there are no neutrophils in the body. That will lead to the exposure to any type of infection at any stage of the disease. Platelet count is 2,64,000. And let me tell you, this is the stage 2. When the stage progresses to stage 3 and stage 4, the hemoglobin comes less than 4 or less than 8, and the platelet count comes less than 1 lakh. That is the stage 4 of CLL. The CT chest and abdomen was done of this patient to see the lymph nodes. Multiple lymph nodes were there up to this size, which were enlarged in pretracheal, paratracheal, precorneal, subcorneal, bilateral, hilar, all ways around. Portal lymph nodes were enlarged. Peripancreatic lymph nodes were enlarged up to 39 into 25 mm. So liver was 14 centimeter and spleen was 13. But splenomegaly we noticed in the clinical examination. So the patient was advised to go for the bone marrow examination or the FISH CLL panel, that is the fluorescent in situ hybridization, FISH. That is a specific cytogenetics investigation for the blood cancer patients. But the patient refused due to the financial crisis because these are some costlier tests, around 20,000 for these, all these together. So treatment was requested on the basis of current data which was available. I had CBC report and I had the CT scan report. So intent of the treatment was completely clear. It was curative intent. In cancer cases, your intent of treatment should always be clear, whether you are going for the curative intent of treatment or you are going for the palliative intent of treatment, because that will change complete course of the action. Carcinosin 201 dose was given to this patient. Natrum Ars was being given to this patient because this is the best remedy in our materia medica for the bone marrow malignancies. Then we have the cyanothus, a wonderful mother tincture which we use in the cases of splenic blood cancers where the spleen is involved, like chronic lymphocytic leukemia and acute lymphoblastic leukemia. Then Berita iodatum was given due to the involvement of the lymphatic system. Not all together, but at every step, because that is a well-designed treatment you need to give to the cancer patient. Carcinosin 1 dose was given in the very initial setup. Then Natrum Ars was continued 3 times a day. Cyanothus was continued 3 times a day. Berita iodatum 201 dose as an intercurrent remedy for once a month. And Macphos was being given for the abdominal pain as well as when the patient requires. So these were the remedies which were being chosen in this case. And after 25 days of treatment, we repeated the CBC report of this patient and there was little bit change. That was hemoglobin 9.3, TLC count from 1,99,000, it came down to 1,84,000. Lymphocyte was still same, neutrophil was still same. So then after 10 months of treatment, I am jumping to the 10th month, but every month the CBC report was being done in this patient. Hemoglobin came out to 14.1 gram per DL. TLC count came out to 7,860. The first one was the 1,99,000. So lymphocyte is 17%, which is lesser than normal. Now see, this is how the treatment works. Now it is less than normal. Neutrophil is 79%. Platelet count is 2,96,000. No clinically palpable lymph nodes and spleen was there. So this case was completely cured without any relapse. The biggest challenge in this case, what? Relapse, the reoccurrence of the disease. Up to 2021, this patient was reporting to me and there was no relapse in this case. That means she was completely cured of cancer. Next case is the chronic myeloid leukemia. This case I added just today morning because the report came today morning that this patient is now almost free from cancer. This case was a cancer case of chronic myeloid leukemia where the myelogenous cells are involved. Refractory to chemo-targeted drug. The patient was on oral imatinib. Imatinib is an allopathic chemo-targeted medicine which is being given to the patients of blood cancers and particularly to the CML patients. So that was 66-year female patient who reported with a known case of chronic myeloid leukemia, which was in the resistant CML phase. CML does not have stages, it has the phases of disease. We have the first is the progressive, then we have the blast phase. So all these types of phases are there in the CML cases. So then this patient came to be having the plug बंद हो गया देखिए So this patient was the 66-year-old female patient with chronic myeloid leukemia that was resistant to the CML phase. So now she was not responding to the chemo drugs. So then they came to me for the add-on treatment in the homeopathic system. BCR ABL1. If you all know, this is the Philadelphia one, what we call BCR ABL1 mutation is the cause of CML. And what we do RT-PCR of the test of this BCR ABL1 to see that how many copies of the BCR gene is having the mutation, ABL1 gene having the mutation. So when we started the treatment of this patient was having this report, pre-treatment report. You can see BCR ABL1 copies were there, 18,024 number of copies were mutated out of 92,000 copies which were evaluated. This is how we interpret this report. The ratio was 19.48%, means total 19.48% of the genes were mutated in this patient. And that patient was regularly taking the imatinib, the allopathic chemotherapeutic targeted drug. Then after 2 months of our treatment, this patient had BCR ABL1 copies, 3429 out of 57,000. So now the ratio came to 5.9, which was previously around 19%. After 2 months of our treatment, it came down to the 6%. Then after 4 months of the treatment, it came down to 27 copies out of 15126, 15,000 copies. And the ratio came to around 0.18%. So this is the third report. And today morning, we had the fresh report of this patient. 31 copies out of 1,24,864. The ratio is only 0.025%. And that patient means that is negligible mutations. And this patient is now in complete remission. And this patient was taking imatinib for almost 1.5 years. And with 6 months of our treatment, this patient is completely in complete remission. And I am expecting that by the next 3rd month report, this will be 0 copies in the BCR ABL1 mutation. So this is how you see that now I am sure that there will be no chance of reoccurrence or relapse in this patient. That is also the most important thing because the blood cancers are very difficult to treat. They always come back again and again. So what were the treatment medicines were given to this? Phosphorus 200, X-ray 6C, and benzenum 6, 12, 30, and 200. So all these medicines were rotated in the patient, along with some immunotherapeutic medicine that we added in this case. Next is a patient that was squamous cell carcinoma of 85 years old patient. This patient was a cardiac patient and she could not be even operated for this tumor you can see on her nose. And then they came to me and ultimately her will to fight, because see, the will to fight is very important in patients. Sometimes what we see, the patient says that I will die now, and ultimately they die. Because the willpower, the psychology, the psychic of the patient is very important. That's why counseling should be done from time to time. So this lady started the treatment and within 3 months of the treatment, she is completely fine. You can see the second picture. And after 6 months of treatment, we repeated her MRI. That was completely clear. And she is, I don't know, now she is, because she was 85 years old 2 years back, up to 2022, she was reporting to me, and now she is off treatment, but I am sure that still she is having no signs of reoccurrence. Then there is a case of adenocarcinoma prostate. That was the stage 4 patient. Gleason score 7 with skeletal metastasis. Now, in allopathic system, when the patient is in skeletal metastatic state of CA prostate, the chances are very high that the chemotherapy will worsen the condition. I have many cases where I have seen that the patients started extensive chemotherapies and their condition started worsening more and more. But this patient refused chemotherapy. They came to us. This was the father of one of the doctor, Ayurvedic doctor. So then, within just 3 months of treatment, this completely regression of the tumor was there. No skeletal metastasis were there, and PSA report you can see, which was around 10.5, despite having no treatment, only orchidectomy was done. The removal of the testicles were done in this case. After the treatment, this patient PSA was 0.032, and till now, till today, last month also we had the follow-up of this patient, and he is completely fine, and treatment has been stopped in this case. Next, we have another survivor. This is a case of CA breast. And this lady came to me in 2017 or 2018 when she started the treatment after the surgery of the breast. And she refused chemotherapy. She refused radiation therapy. She was exclusively on homeopathic treatment for last 5 years. And till now, she is on treatment. And this patient is having no single reoccurrence evidence in the last 5 years, because in cancer, what we calculate, the 5-year survival rate. That if in the first 5 years of the treatment, the patient has no signs of recurrence or no relapse, then this patient will be cancer-free, because getting a certificate of cancer-free takes 5 years, right? So this patient is almost up to complete the 5 years, I think within next 2 or 4 months. So she will be completely fine in this period. Now, this was all about the curative treatment. This much scope we people have. But the thing is, the right choice of treatment, guidance to the patients, and knowledge of the disease plus knowledge of the conventional system also, because when you are treating a patient, you should be aware what chemotherapy the patient is taking. That is also very important. What it can benefit to the patient, it can cause damage to the patient. You should consult the family also. Next, we'll talk about the cancer palliative medicine. The palliative approach in cancer, what we can do for those patients who are not up to the mark to get into the curative intent. When the disease has completely exhausted, we can simply palliate and we can give the quality of life to the patient. Life is pleasant, but the death is peaceful. It is only the transition which is troublesome, from the life to the death, which always causes the trouble. And if I talk about the cancer patient, we see that in cancer patients, this is the most troublesome part. The last days of life, the terminal stage. We have seen people suffering from pain. We have seen people suffering from vomiting, loose motions, no appetite, completely on bed. And that is the worst part of the disease. So our approach is the quality of life should be given to the patient. There should be no hospitalization. There should be minimal medications. There should be extension of the life, whatever you can do to this patient. This is a very wonderful poem written by Dame Saunders. He is the founder of the hospice care. You matter because of who you are. You matter to the last moment of your life. And we will do what we can do. What you can do for the patient in the last moment is also very important. Not only to help you die peacefully, but also to live until you die. Because see, many times what we see in the hospitals, they say, take your patient and do service at the home. This is a very common thing that we see in our day-to-day practice. But where those patients will go, because in our country, particularly in India, palliative care is very poor. And if I talk about palliative treatment in our system, that is far 1,000 times better than the conventional system, 1,000 times. So palliative care is what? It is the symptomatic management of a chronic or life-limiting illness, and hospice care is the comfort care at the end of the life. So this is the two ways of treating a patient. Now coming to a very different case that I had seen, I think 4 or 5 years back, that was the case of bifrontal meningioma. And that happened post-surgery with encephalomalacia, obstructive hydrocephalus, a very critical case that was being brought to me, bifrontal meningioma that was relapsed after the surgery also with obstructive hydrocephalus. 65 years old patient, daughter, she came to me with only the radiological investigations and a hospital summary which stated that post-surgical excision of the bifrontal hemangioma, the patient developed pneumocephalus, obstructive hydrocephalus, and encephalomalacia, means the surgery came to be a failure in this patient. And surgery could not give any benefit to this patient, but it worsened the situation that became a severe case of pneumocephalus, hydrocephalus, and encephalomalacia. Hospital summary: as the patient is not responding to the standard treatment protocols and her neurological complications cannot be managed conservatively, she can be taken home for palliative home care. The same thing I told you, that hospital simply refused, that we cannot do anything now, take this patient home and do whatever home treatment you can do for this patient. This is the patient on the 4th of July 2016. Let me show you this video. I think, hope this video will work. Just have a look on this patient and tell me what Glasgow Coma Scale, GCS scale, is in your mind. Either I have written it, but still you calculate at your over and also.
Sudeshi is there?
Look at the arm of the patient. There is no eye movement, there is no verbal response, and there is abnormal flexion or extension of the body part. So that means what? E1, V1, and M3. That is the severe grade of the Glasgow Coma Scale. That means this patient is into the pre-comatose condition. Now, what is the first thing that we need to do? Please put in the chat box, what is the first thing we need to do in this case? Forget cancer, forget hydrocephalus. What is the first thing to do or to manage in this patient? Fast, put in the chat box. We have very few minutes left. Anybody? To prevent coma, to release cranial pressure, right? Dr. Sonika, right? To prevent coma, so that the patient should not land into the comatose condition, and that will happen only when you release the cranial, intracranial pressure. Carbo-Veg 1M. No, sir, Carbo-Veg is not the right choice of remedy at this time. Let me tell you what is the choice of treatment. The first visit of this patient, we have the low-grade fever, oligouria, no urination. Is anuria, but oligouria means urination is decreased. Senses are diminished, vomiting, that is non-projectile vomiting, and the patient is moaning in the sleep. So, midline shift of 4 mm in MRI, raised intracranial pressure. The patient was taking the allopathic drug Diamox, which is the acetazolamide, which is given to the patients of increased intracranial pressure as a diuretic. Diamox, only single remedy they have. Somebody is saying, Dr. Naeem is saying Apis mellifica. See, we need a medicine which should be a diuretic also, which should be anti-comatose also, which should be having a good anti-inflammatory effect also. And only remedy that comes to my mind in this case, let me tell you in the next slide. Now, most important question is that can we do anything in this patient in OPD? We people don't have the IPD setups. We don't have the hospital setup. On the first minute of sick patient's visit to your clinic, you should keep in your mind, this is a very important thing to understand, you should keep in your mind that now this life is your responsibility. The moment patient is inside your clinic, this is your responsibility. Whatever happens, that will be your responsibility. And you need to make it clear to the attendants that what can be done for this patient and what can not be done for this patient. Very clearly, it should be given to the, in writing even you can give that this is the exact condition of the patient. I can do this much for your patient. And ultimately, the condition is not that much good. And written consent can also be taken. Because I always say that we cannot put scrambled eggs back into the shell. We are not superpowers. Always people believe that I will do this thing. Always believe whatever you do, you should explain it. You should have answer to that. Because at the end of the day, the doctors are the only people in this planet who have to answer for multiple lives, not only your own, but also the patients' your lives. They have also to be answered at the end of the day. So now, case review was done. We need a drug which could help with the neurocongestion as a diuretic due to hydrocephalus and encephalomalacia with sedative and analgesic effect. And only remedy which we have in materia medica is opium. I was aware the people will say opium. We have arnica montana. Wherever comes coma, never believe only opium is the choice. I told you anti-inflammatory also. Very important clue was being given, anti-inflammatory. And above arnica montana, we don't have any anti-inflammatory in the materia medica. So active component of arnica. Now I am telling you why. Active component of arnica is sesquiterpenlactones. This is the active principle which has anti-inflammatory, neuroregenerative properties along with sedative and analgesic effect. So 4 features it has: anti-inflammatory, neuroregenerative, sedative, analgesic. So ultimately, arnica 10 and 3 doses were given to this patient at a gap of 1 hour. And other medicines for vomiting, we gave apomorphinum 6 and Apis 200 was the diuretic for this patient. Now this is a second video after arnica. You can see what is the difference.
सुदेश जी इधर देखो शाबाश.
Eyes are open.
अखा खोलो दोनों.
Verbally there is no response. The flexion or the extension is completely gone, and that is localizing. The patient is putting it on the localized part.
हाथ ऊपर चखो. ऊपर चख लो. अच्छा शाबाश. हाथ ऊपर करो. शाबाश. सीधा कर लो हाथ.
She is pointing to her head.
सीधा करो.
Maybe it was the headache that was causing her, because her senses are back now. She is in a more sensitive condition.
सिर दर्द हो रहे.
Glasgow coma scale is now into the
सुदेश जी.
severe grade to
सिर
moderate.
दर्द हो रहे. हाथ चख लो ना. इधर रख
She is
लो.
having no verbal response at all.
हाँ देखो शाबाश. ऊपर देखो.
That was the changes after arnica 3 doses. Now after 2 months of treatment, the patient was improving when she had 1 episode of seizure, and that was an indication of neuropathological insult, which was not favorable for this case, and midline shift came to 2 mm in this case. That was a good sign, but ultimately now see this video that what happened to this patient.
उल्टी हो रही है. उल्टी हुंदी क्या खाज हो रही है. खाज हुंदी नहीं. फिर क्यों कर दे पे. इत्थे रखो. पेट ते रखो. हाथ नू पेट ते रखो. चलो पेट ते रखो. अख खोल के
She is
दिखाओ.
pointing out to her head now. Senses were more better. Now she was being shifted to Helleborus 0/1. Why? Because we need to having a good diuretic that patient's urine output decreased in last 24 hours. So now her BP has started falling. So after that, we added the Helleborus 0/1 that was being given too early, along with nebulizer of antimonium tart 200, just nebulized, not the internal, but the nebulized. So her daughter marriage, that was a very emotional part of this case, because being a doctor, we know that our emotions are not that much required in some cases, but when you are treating this type of cases, what happened in this case, her daughter had the marriage on the 1st September, and that was having only 3 days left from the follow-up. And she started crying and told me, sir, anything you do, but keep my mother alive for 3 days. So now you can see what is the role of palliative care. She was crying in front of me that I just need my mother for 3 more days. That was the time when I felt personally that medical science is still helpless when it comes to the Almighty. So now what we did, supportive drugs were set in so that we could keep her alive for another 3 days. There was shutting down of the system very gradually, we could see. She was holding her breath. Viscum album was added as a diuretic, digitalis was given as the vasopressor, and cupromet was being given as an anticonvulsant. Now, 3 medicines at single moment I was giving to this patient, because this is the part when the vital force is in suspension. And Dr. Henneman has written, when the vital force is in suspension, you can take the palliative care at most. And palliative care does not mean that you need to refer the patient to the allopathic hospital. You can manage with your skills also. So Viscum album, digitalis, cuprum, met together were given so that the patient could be holded for at least 3 days. Ultimately, she could attend her daughter's marriage. I think 3 to 6 days passed, because that was on 3rd, now it is 6th September. So 6 days passed, she was still alive, and the patient was brought in the collapsed condition on the 6th of September, and the BP was 60 only systolic. Heart rate was 120, respiration was 28, SpO2 was falling 92. And I was not at my clinic, and ultimately told one of my staff to give cuprum metallicum 10 stat, because till I arrive in next 15 minutes. Cuprum met was given to this patient 10 in stat dose. Now after that, she regained conscious, looked at her daughter, vomiting twice inside my clinic, and BP was 90/60, that improved. And I told them to take to the tertiary care, but they simply refused, that till now you are doing best for our patients, so we will not take it to any other doctor. Carbo-Veg 0/3 was being added hourly. Apocyinum Q, diuretic this time, and digitalis Q was added 3 hourly. So treatment was being advised for the home. 7th of September, the patient remained almost stable till that time, took some tea, juices, fruits in last 24 hours, and slept for 3 hours at night. Remained conscious for the whole day, listening to the family around, and around 4:30 p.m. she collapsed with her dropping pulse, and the family told to not to give resuscitation to the patient. There was a DNR consent given by the family, do not resuscitate. Ultimately, this patient collapsed on 7th of September. Now, this is the importance of palliative care and how you can manage the critical cases also at home care. But you need to be very precise, accurate about your medicine selection, that at what moment you need to manage it. So now why cupromet was given, not Carbo-Veg? Because when you have tachycardia with hypotension, remember, tachycardia plus hypotension, blood pressure is low, but there is high heart rate. Carbo-Veg is simply ruled out, because Carbo-Veg suits the hypovolemic shocks. And in hypovolemic shocks, the pulse starts falling down. So sudden loss of consciousness in neurological pathologies. If anybody has brain tumor, epilepsy, any type of neurological complicated disease, or any pathological deformity in the brain, if that patient collapses, cuprum metallicum is the first choice of remedy. So that's why Carbo-Veg was not given in this collapsing state of this patient. So that was all for today. Any doubts you can ask me, and thank you everyone for listening patiently, and I think we are up to the time. So any doubts you can put in the chat box, and Dr. Pavneet, please continue with the doubts so that you can answer everything. Thank you once again. Okay, let me check what are the doubts. Anybody else having the doubts, you can put in the chat box. Why arnica 10M hypotensive as a pathological prescription? Arnica 10M was not given as a pathological prescription when the patient is in the highest suspension of the vital force. Highest suspension means like in the comatose condition, like in the cerebrovascular accident situation. In those cases, the dynamicity of the disease is very high. So you need to prescribe the highest dynamic potency which you have available so that the dynamicity should be matched together. So that was one given in the 10M, because in emergencies, you always prescribe highest potencies available, right? Medicine for CA prostate. There are many medicines CA prostate. We have this subalcerulata, we have chimephila, we have lycopodium, we have pulsatilla, we have selenium, we have beritoidatum. Why diuretics were changed from epis to viscomalbum to eposinum? Epis was given at that time that I told you. Eposinum is in the materialistic dose, because when you are dealing with a critical case, you need to infuse more critical this medicine at the moment, like in the materialistic doses. And eposinum is the best choice of remedy when you have the abdominal or the neurological edema or any sort of fluid accumulation. Any other doubt? Yes, anything else to be asked? Right. Dr. Arun sir, you are there? Dr. Arun sir, principal of BVS College. Okay. Right. So thank you all to be the part of this session. And we hope that this would have been a wonderful experience for all of you. And any doubts, if you have a group already being prepared, you can put in that group and I will make sure that that will be answered over there. So thank you once again for joining this session. Thanks a lot.